Our first speaker today is Professor Harry Janssen, who's chief of the Hepatology Center at the University of Toronto. And he'll be talking to us today on when to stop nucleotide analogs in chronic hepatitis B. Harry, a pleasure.
Thank you very much, Mike. Thanks, Marcus. Thanks, Stefan and Ira, for inviting me here to Frankfurt. Within my talk, I would like to take you with me through the journey on particularly when to stop nucleoside analogs in the treatment of hepatitis B. And there's a lot to say for stopping, but there's also a lot to say for continuing therapy, because the treatment as we have it now in our hands is very simple. The nucleoside analogs, it's safe, the side effects are very limited, they're very potent. They've been shown to reverse fibrosis and decrease the risk of liver cancer, decompensation, and death. They tend to get cheaper with time, and there might be a risk of relapse when it is stopped. These are some data on over the decades, actually over the last 2 decades, we were first able to show that we could get the virus undetectable. In the second stages of the studies, we were able to show an improvement of histology, in particular in fibrosis as well, and even reversal of cirrhosis. And the last study, with even prolonged follow-up, we were able to show that we can really reduce these hard endpoints like liver cancer and mortality. If you treat patients with hepatitis B with nucleoside analogs, we know that the viral load goes down very quickly, but we know also that the S antigen level rather stays very flat or goes down very, very slowly in only a minority of patients. In fact, mainly, I would say illustrating that we do get viral control, but we'll get very limited immune control over the virus with these agents. These are data from my own group, published a few years ago in Journal of Infectious Diseases, where we showed that the S antigen level on nucleoside analogs was going down only very, very slowly in E antigen positive patients, fully suppressed virally, and it hardly went down at all, actually, in E antigen negative patients. And if you calculate by statistical modeling how long it would take to get these patients S antigen negative, you're up to almost 4 decades, so that's a very long time. There's also a lot to say on whether we should stop treatment, because there would be no reason to continue taking a drug if there would be no further benefit. There's definitely long-term side effects, which might be a problem. We've been giving these drugs now for 5-10 years, but if you have to give them for 4 or 5 decades, that will be a different story. There's issue of drug adherence and follow-up of attendance issues. Younger patients tend to find it difficulty to accept lifelong therapy. There are women who want to become pregnant and in whom we might do stop treatment, which we don't want. There's working days lost to hospitals. There's obviously a big cost issue if people have to be treated for a long time, particularly in developing countries where they're not that rich. And there's the potential benefit of treatment discontinuation. So from a theoretical viewpoint, it's very questionable whether we could stop treatment at all, because if you look at where these agents interfere in the viral life cycle, it's a rather late step, and the cccDNA, which is considered to be the template of viral replication, is largely unaffected by these agents. So we need more answers, I think, overall, to really stop nucleoside analogs in our general practice. We need to know what is the risk of relapse, and then there are different definitions of relapse, whether it's virological, biochemical, decompensation. Can we predict those patients who will relapse? How do we manage patients who stopped therapy? When do we restart? And are there benefits, as said, of discontinuation of therapy? So let's have a look at what the guidelines currently say. The American guidelines, which are older and currently being updated, say that we can stop in E-positive patients 6 months after E-antigen seroconversion and undetectability of HBV DNA. And in E-negative patients, they they advise us to continue until S antigen clearance. In Asia, kind of a similar approach for the E-positive patients. 6 months after ECO conversion could be stopped, and 12 months kind of consolidation therapy in the E-negatives, which is, I think, a very short period of time, particularly for those patients. And the EASL guidelines give a little bit of a longer consolidation therapy advice for the E-positive patients, namely 12 months, and they don't give an advice, I think, for the E-negatives, but I think within the text it's mentioned that it might be best to continue until S loss is there. So let's look at some data. So let's first look at data stopping nukes after E-antigen seroconversion. And this is one of the first study published from my own group in gastroenterology a couple of years ago, where we looked at the validity of E-loss or E-seroconversion as an endpoint in nucleoside analogs. And what we found is actually that it wasn't a very firm endpoint, and probably not as immunologically sound as in the natural history of the disease or even patients being treated with PAC interferon. Because we did see reappearance of E-antigen quite a bit, and if we looked at the confirmed reappearance, it was still up to 44%. We had limited amount of patients who stopped treatment. Many of these patients were treated with lamivudine, and they developed resistance, and for that reason even get an E0 reversion. But even in those patients who were completely treated according to all of the guidelines with sufficient consolidation therapy, we saw pretty poor results, with only 22% of the patients who remained in remission. So the conclusion of that particular paper was that recurrence is likely to occur when the suppressive effect of a nucleoside analog is omitted, whether by discontinuation of therapy or by the development of antiviral drug resistance. In other words, on-treatment resistance mainly happened in patients treated with lamivudine due to resistance, but off-treatment recurrence happened in all of the patients, also those treated with our strongest agents like entecavir and tenofovir, and irrespective of consolidation therapy. And the conclusion of that study was that long-term nucleoside analog therapy might be necessary. If you look at other studies from Asia in particular, there's one study from Korea with 178 patients in whom nucleoside analogs were discontinued after ECO conversion. They saw a lower relapse rate of 30%, but it's very important to see how you define relapse, because in this particular case, it was defined by the HBV DNA detectability by the older dye gene assay, which has a cutoff of 10 to the 5th copy, so which is not very sensitive. And obviously, the higher you make your barrier for relapse, the less patients will have a relapse. In Singapore, Sengi Lim did a retrospective study looking at E-antigen loss among patients with nucleoside analog treatment, and he showed indeed what we already suspected, that most probably a nucleoside analog-induced E-loss or E0 conversion might be immunologically different, less sound as in the natural history of the disease. And in this particular case, he saw more relapses among drug-induced E0 conversions than in the spontaneous E0 conversions. This is another study that we recently published where we, in fact, added on PAC interferon to entecavir. This is the so-called ARES study that we performed in Europe and in Asia. And if you look into this pie chart, you see in the top half, you see the entecavir PAC interferon add-on arm, and in the lower part, you see the entecavir monotherapy arm. With E-antigen loss and normalization of ALT as an endpoint, first of all, you could see that in the PAC interferon add-on arm, you would have a higher response rate than in the entecavir monotherapy arm, if you look at E-antigen loss. But more importantly, the sustainability of a PAC interferon E-antigen loss was higher than just an entecavir-induced E-antigen loss and response. Again, pointing to the fact that, I mean, an E0 conversion under different treatments might not be comparable. So what about stopping nucleoside analogs in patients who are E-antigen negative at the start of therapy? So we're not talking about E-loss or ECO conversion, but patients being E-negative, put on nukes, and then stopping therapy. This is a study published by the group of Henry Chan in Hong Kong, where entecavir-treated patients, E-negative, were discontinued. And he saw a huge amount of relapse, up to 91% of the patients. However, this study was criticized by the fact that patients were put on treatment rather soon. If the HBV DNA just hit the level of 2000 once, they were immediately retreated. And many of these patients actually did not have elevated ALT, so not truly active disease. And it is kind of interesting, as I'll show in other studies which have been published, to not restart too quickly, because off treatment, interesting phenomenon happens, particularly in E-antigen negative patients. This is another study published, in this case from Taiwan, from the group of Zhongfeng Liao, who actually wrote the APASO guidelines and then tested this on his own patients, kind of the butcher testing his own meat. And he found that roughly half of the patients relapsed, and the conclusion of the paper was rather positive, that you could easily stop treatment in patients being treated with nukes in E-negative disease. I did write an editorial on that, which was a bit less optimistic, because the problem of this particular paper is that it had only 1 year of follow-up, that patients with less than 48 weeks of follow-up were excluded from the analysis. One patient had decompensated who had cirrhosis. And the problem of all of these curves is that the follow-up is pretty short, and the curve does not seem to plateau. So I'm showing you a lot of Kaplan-Meier curves in this talk. And the problematic thing is that it doesn't seem to level off. So the longer you wait, basically, potentially the more relapses you might get. This is a study published by Stefanos Hadzianis, which is referred to many times. And it's a very interesting study, I would say, because in these 33 patients from Greece, all genotype D, being treated in the big adafovir study, he discontinued therapy, and many of these patients relapsed, but he had a fair amount of patients with a sustainable response, basically. And the pattern that he saw is that the HBV DNA went back up. Some of these patients developed a flare, and he was courageous enough just to wait and not to retreat. And what he saw is that several of these patients became S-antigen negative over time, or got into a remission otherwise, so very low HBV DNA levels and no inflammation. So this led also to another study, which was recently presented by Thomas Burke at EASL, where for the first time in a randomized fashion, treatment was discontinued. So what Thomas and his German colleagues did is they looked at E-antigen negative patients who had been on treatment for quite a while already, for more than 3 to 4 years, and half of them were continued on treatment, the other half was stopped. And he presented the results of week 48. And if you look at the HBV DNA profile, it's a very interesting pattern, because first of all, the HBV DNA became detectable in all of the patients where treatment was discontinued, and obviously in none of the patients where treatment was continued. The HBV DNA went up, but then again, at week 48, roughly 52% of the patients had an HBV DNA still underneath 2,000, and 62% had values underneath 20,000. He presented the data excluding the patients who were retreated. There were 3 patients who were retreated, who are in orange here, in fact. I kind of modified these values and looked at the intention to treat analysis, which doesn't give that good figures as what he presented. Still, it's interesting to see that several of these patients appeared to go back into remission after the HBV DNA went up. He also looked at the ALT profiles. He had some nasty flares. That's also our experience. We have stopped several patients in Toronto as well as in Rotterdam. And you have to be very careful, because some of these patients flare up to way into the hundreds and even above 1,000 ALT value. So if you would stop, monitor these patients very carefully. Again, after week 48 follow-up, roughly half of the patients had a normal ALT in this particular case. And the truly interesting part of this study is that if you looked over time, 2 of these patients became S-antigen negative, and the profile tended to get better a bit. So it's a very strange phenomenon, but the ALT tended to go down, the HBV tended to go down, and in particular also the S levels tended to go down. So if you stop treatment, you're definitely shaking kind of an immunological tree. You're waking up the immune system and getting S antigen decline and S antigen loss in a selected proportion of your patient, which obviously does not happen, as you can see here on the right side of this slide, if you continue nucleoside analogs. So there is a risk of virological relapse, which is pretty firm, I would say. But in the meantime, you might push some of these patients into immunological control over the virus. So the question with all of this, is the glass half full or is it half empty? I'm not sure yet. I thought it was half empty and it would get more empty with prolonged follow-up. With these recent results, I think it's very interesting to see that indeed the results from Stefanos Hadzianis were kind of confirmed by Thomas Beck, and we need more studies on that. So the question is, what is the role of consolidation therapy, and can we predict those patients who truly get a sustained response of treatment? If you look at the consolidation therapy, this is one of the first studies on which many of the guidelines actually based their recommendations, and I do think the guidelines might need to be changed regarding the consolidation therapy. And this is a study where I referred to earlier, where those patients who were treated after E seroconversion for at least another year had a much lower relapse rate than those who were treated less than a year. But again, here the HBV DNA value to define relapse is rather high, and that really needs to be redone with more sensitive assays. This is a study published by Heng Chi from my own group, where we looked in 94 patients from Toronto and Rotterdam who discontinued therapy. And at 3 years, 75% of the patients developed an HBV DNA above 2,000. This is combined E positive and E negative, so patients after E seroconversions and E negatives at the start of nukes. So 75% developed a single time point with an HBV DNA above 2,000, whereas a persistent virological relapse with at least 2 tests with an HBV DNA above 2,000, 6 months apart within a year, was found in roughly half of the patient. And if we looked at the value of consolidation therapy, it tended to be that the longer the patients had been treated after E seroconversion or anyhow in E antigen negative patients, the less likely they were likely to have a relapse, basically. And if you look at the values rather at 3 years consolidation therapy, the results become significant, and the 95% confidence interval goes below 1. So in our hands, if you would do a consolidation therapy, half a year or 1 year is probably too short, and we might need to treat much longer, and probably the longer you treat, the better it is. This is another study which looked basically, it's from Korea again, it looked at the prediction of relapse or sustained response in those patients where you discontinue treatments, E-negative patients. And what they found, and that's coming out of more studies, and particularly the S level at the end of treatment, is probably our most significant and our best factor to predict which patients will not relapse, so will have sustained response. And most probably a rather low level of S antigen, below 200, is your best bet to keep people in remission after you discontinue therapy. There are other studies done in E-positive patients predicting responses. They're rather contradicting results, whether age and consolidation therapy duration affects the off-treatment response. There's also one study looking at baseline HBV DNA as an important factor. In the E-negative population, as I just mentioned, the S level decrease, and in particular the end of treatment S level, is an important factor. And there's another combined E-positive and E-negative cohort where the presence of LAM resistance, the time to undetectability of HBV DNA, and the end of treatment S antigen level were independent predictors of sustained response. what about if a patient does develop S antigen loss in nucleoside analog? Is that sustained? Because we probably know that E antigen loss is not as sustained as in the natural history. What about S loss? This is a study from South Korea again, a very big study published in Gut, where they looked at 110 patients who developed S antigen loss, S seroclearance, during treatment with either lamivudine or entecavir. And 110 seems to like a big number, but mind you that more than 5,000 patients were treated here. So the overall number of patients developing S antigen loss in nucleoside analog treatment remains to be very, very low. You have to keep that into mind. In any way, most of these patients did very well. They saw no patients with an HBV bouncing up to above a level of 2,000, and they saw very few patients with an HBV DNA level moving up to above 60, and in most of them the HBV DNA went back again, and in some of them even the S antigen level stayed negative. So this seems to be pretty sustained, unlike E antigen loss or seroconversion. Here again data from my own group, where we found, in fact, 9% of our patients who had some kind of detectable viremia or S antigen recurrence after S antigen loss in the setting of nucleoside analog treatment and discontinuation. And we saw no flares, no decompensation, and again, a similar pattern that indeed some of these patients had a little bit of viremia, but clinically they truly stayed in remission. So in conclusion, Mr. Chairman, ladies and gentlemen, I think many patients with hepatitis B relapse after we stop nucleoside analogs. And therefore, in the majority of patients, these patients have to be treated very long, if not indefinitely. E antigen loss is probably a suboptimal endpoint for nucleoside analogs. The role of consolidation therapy is unclear, and probably the longer the better. Monitoring of S antigen levels may help to identify those patients who can stop nucleoside analogs, where an S level of less than 200 might be of help, but definitely more research in this field is warranted to identify better predictors of off-treatment response. Stopping therapy does seem to evoke some kind of immune reactivation by the very rough biomarkers that we use of HBV DNA and ALT, but unfortunately, truly no good immunological studies have been done in the setting of discontinuation of treatment, and it's one of the aims actually of the NIH cohort of the HBRN, where several of us are involved in. And we definitely will have a shift towards endpoint of S antigen loss. We're very well able to get the HBV DNA undetectable in hepatitis B. We're not well able to get S antigen loss or even better S antigen seroconversion. So what is my kind of personal approach in all of this? I would say in regular clinical practice, I'm very reluctant to stop nucleoside analogs until S antigen loss. Important consideration in all of this is the patient age, the motivation, and particularly the ability of follow-up. Don't stop these drugs and just send these patients back to the family doctor, because you might run into disasters. If patients really want to stop therapy after E seroconversion, I particularly do that with long-term consolidation therapy, and both for E positives as well as for E negatives, where a low-end S antigen level might help me to convince to do that. I do not stop treatment in patients with compensated cirrhosis, and I continue until S antigen loss, and I never stop nucleoside analog treatment in decompensated cirrhosis. Thank you very much for your attention.